Yes, sir.
Good afternoon, friends. I welcome you all to this instruction course on tackling medical emergencies in eye care practice. I am Dr. NIRMAL FREDRICK, the chief instructor for this course. I have no financial interests, work in honorary capacity as NABH principal assessor and full-time consultant at NIRMAL Eye Hospital, Chennai. So this instruction course is on managing medical emergencies in eye centers. I have with me my co-instructors, Dr. Atik Sheikh, Dr. Sunita Nirmal, Dr. Gagan Dudeja, and Dr. Kumaran Murgesan. Welcome, folks. As you all know, eye centers are under-equipped, unprepared for the surprises, and many of them don't have ambulance for transfer arrangement, and the team strength is inadequate in terms of numbers, experience, expertise, and training. So this instruction course is basically on how to assess patient plan for OP surgery, how to sense and save a sinking patient in OPD, what are the equipments and training required for managing emergencies, how to call a code blue, and should we have an anesthetist during surgeries, and what exactly are the NABH standards with reference to acute care and emergencies in daycare centers, and certain relevant issue with reference to patient management and some interesting case studies. So medical emergencies, as you all know, are rare medical events that may occur in the OPD or OT, since many of our OTs are daycare OTs. If we encounter these events, it requires immediate diagnosis and management to avoid potential consequences. So we should be ready for the life full of surprises and be prepared to save a life. Once you have this medical emergency, first thing you have to learn is to not panic. And we should be prepared to encounter medical emergency because it's part of our patient care at any point of time and any day it can happen. An important benefit learning CPR or this emergency procedures can give you is the ability to save lives. That's what you get out of this. And also you get empowerment and better confidence level in managing your practice. You are helping someone in their need and creating a hero out of you, and that's beyond the call of our duty. And it also saves yourself and your practice. And for the hospitals, having a number of certified BLS staff, we have more confident, trained staff. The survival rate of emergency patients increase. The transfer process takes much less time. Reduce incidence of medical legal challenges, and a happy team and happy patients. So this is the overview of this instruction course. Dr. Atik is a consultant ophthalmologist at Fatima Eye Clinic. He'll be talking to us about how to assess a patient plan for OPD surgery. And Dr. Sunita Nirmal is a consultant at NIRMAL Eye Hospital. She'll be talking to us about equipments and training required for emergencies and code blue drill. Dr. Gagan Dudeja is a consultant at the Narayan Netralaya and also a senior NABH assessor. He'll be talking to us on NABH standards on acute care emergencies. Dr. Kumaran Murgesan is a practicing ophthalmologist at Kumaran Eye Specialty Center. He'll be discussing about certain case studies on how he managed medical emergencies in his center. And last, most of us, after going through a crisis, are really scared about having these kind of emergencies in our practice and how to tackle this and also manage the other stakeholders in our practice. So stay with us for the entire course, and I'll start my topic. The first talk is on how to sense and save a sinking patient in eye centers. Just start with certain scenarios. This 35-year-old lady came for an incision and curettage for Calassian, and she was on preparation for OP procedure, and injection xylocaine test dose was given. This patient reports to the reception. An appointment was scheduled. After registration, she is seated in the waiting hall. The OP got delayed. She's restless after 25 minutes and keeps saying, I'm not well, have to see the doctor immediately. But the optoms or the reception people have made her wait politely. The third story is on a 50-year-old gentleman waiting in OPD. Is on for a regular follow-up, diabetic patients, and suddenly get agitated, starts verbal abuse, starts sweating profusely and tremors. So what do we do? And 89-year-old male posted for cataract surgery, anxious. The BP has gone to 180, 110. And in spite of all types of local anesthesia given, patient is restless. So back to the first patient again. So once we reach out to her in the OPD, she starts itching and suffocating. She's awake and oriented, but her breathing fast has become fast, and she's getting tired, and also developed hoarseness of voice and generalized flushing. These are the vital signs. 124 minutes, that's tachycardia, respiratory rate is increasing, and the saturation has come down, the BP is coming down. So these are the situation that really triggers a panic in our mind. And the hints to the diagnosis or how to go forward is the acute onset, secondary to a trigger, particularly the injection xylocaine test dose. Patient has a sense of impending doom and hoarseness of voice. So this is anaphylaxis, and you can see that patients suddenly from a good situation, she is turning into bad patients. Anaphylaxis is an acute, potentially fatal multi-organ system reaction, and this is a classic form of anaphylactic reaction. So how do we investigate? Anaphylaxis is a clinical diagnosis, and investigations are not helpful in the acute setting. And we have to recognize it as soon as possible, and you have to ask for history of recent anaphylaxis. And once a sudden onset of signs and symptoms happen, within minutes, you have to initiate treatment and the management part. It affects more than one system, and you also have to know that local anesthesia test or allergy can occur due to the drug or to the preservative, and can happen with any type of local anesthesia. So initial steps in the management of anaphylaxis has to focus on this ABC, airway, breathing, and circulation. And we have to immediately assess the airway. That's a key initial intervention, and start on medications like adrenaline, hydrocortisone, and antihistaminics. And also have to support the patient with oxygen, cardiac monitoring, IV access has to be done, and patient has to be positioned comfortably. And another team has to arrange for transfer an ambulance, or if you have a nearby center or within your center, you have to transfer the patient to safer confines. So coming back to our second patient, presenting with classical symptoms of cardiac arrest, chest discomfort, sweating, upper body discomfort, nausea, shortness of breath, and lightheadedness. And our trained emergency staff calls for a code blue, recognizing based on their training and also how to knowledge about how to activate code blue situation. And code blue is activated. Patient is by the time non-responsive, no breathing or no neck pulses. CPR initiated, and then patient is transferred to nearby hospital, admitted in the ICU. Code blue, as you all know, is meant for emergencies in medical field, particularly cardiac arrest. And the third patient, again, as I said, in a busy Saturday OPD, started on with verbal abuse, and the staff were really taken back with the verbal abuse, and suddenly patient started sweating profusely and with tremors, and suddenly falls to the ground with hands on her head and sweating. And these are the classical signs. So we have to know whether is it an emergency. So we see the vitals and check the blood sugar. The sugar was 62 milligrams. And so what do we do? So started treatment for hypoglycemia, gave oral sugar, as well as started with IV dextrose as well as oral dextrose. Patient got stabilized. And the fourth patient, just before the surgery, was very anxious with a high blood pressure. And luckily, we had our anesthesiologist nearby. So he checked the monitor, he gave IV midazolam, sedated the patient. Patient settled immediately. Blood pressure came to 130/90, and he was monitored under the anesthesia care. With vigilant monitoring and early diagnosis, we were able to perform the procedure, and he went happily. So medical emergencies can happen anytime, any day, in any center. So debriefing, how are our patients now? The first patient is doing well, did well, admitted in the ICU, recovered in 6 hours. This was the monitor signs after 6 hours, and patient was sent home, and great job. The second patient who suffered a cardiac event recovered in the ICU, treated medically, and then with lifestyle modification, she is recovered well. The third patient who was on hypoglycemia went on to have the procedure and was a happy patient and gave a lot of good reviews about our hospitals. And these kind of emergency situation in daycare centers can happen. So particularly common are these hypoglycemia, anaphylaxis, particularly when you are doing FFA or giving local test dose, asthma exacerbation, seizure, impaired consciousness, and cardiac arrest. So there are many ways of being sick and defining critical illness. So how to prepare our center and our staff. So in the reception and waiting hall, you need to train our staff, and you need to have intelligent reception people. They have to inquire with patients who are reporting sick, check the vitals, and if it's always better to have a trained nursing staff in the OPD to check the vitals and blood pressure, heart rate, and respiratory rate. Having a CCTV really helps, particularly the third patient who had hypoglycemia. So we saw the patient really disturbed, and then went to the OPD and saw that her sugar was low, and immediately we were able to resuscitate her. And very important, we train the staff and also have equipments, particularly cardiac monitors, SpO2 monitors, particularly during COVID season is important that we have a SpO2 pulse oximeter and good monitor, as well as blood glucose monitor. It's very important all of them who report with such signs are monitored for the vital signs. So from history, you have to look for red flags, immediate assessment of the patient, and intervene with whatever essential medicines as well as monitors you have. Then diagnose the condition, reassess as frequently as possible, communicate to the patient, communicate to the team, communicate to the ICU or nearby hospital. And also important that you know your patients, particularly elderly patients who have a different kind of response. And you should also have a gut feeling that some patient, someone who is really disturbing you, being unwell or deteriorating, and also have to take inputs from the attenders or the family. And keep an eye on high-risk patient groups, particularly vulnerable elderly patients, multiple comorbidities, patient on wheelchair or stretcher-bound patients, and patients referred from other clinics or hospital. You need to have a high-risk sensitization in your mind. So during the non-emergency phase, in the emergency phase, you have to activate code blue or other emergency measures and deploy all your communication skills, reporting mechanism, and involve the team in managing the crisis. And post-deployment, post-emergency phase, you have to develop the standard operating, review the standard operating procedures, retrain your staff, debrief your staff, and keep them ready for another set of emergency exercises. These are some of the reviews we get, particularly patients who had some issues in the hospital, then recovered, and they go on to give good reviews about patients. So it is recoverable. Any emergency stage we can recover, and nothing can replace the skills, knowledge, and abilities and teamwork. So to summarize, the care starts at the doorstep. Vitals are important, vital. Know your patients, particularly review and vulnerable patients. Equip and train the staff, and knowledge, skill, and teamwork will really help us to manage any crisis in the hospital. Problems are not stop signs, they are guidelines, and we should ensure that we take this as a lesson and install proper mechanism to develop emergency care system in our hospitals. Thank you so much for your kind attention.